We'll start, Sumati.
Yes, ma'am. We welcome all with a very, very happy and a prosperous new year from OGSSI. And we are glad to invite all of you on behalf of the Public Awareness Committee of OGSSI for this Thinnai debate webinar. அண்ட் திஸ் திண்ணைன்னு இதுக்கு பேர் வச்சிருக்கிறதுக்கு ஒரு ரீசன் இருக்கு. அந்த காலத்துல எல்லாரும் திண்ணையில உட்காந்து கதை பேசுவாங்க. ஸோ திஸ் பப்ளிக் ஃபோரம் நாட் ஓன்லி ஹேஸ் டாக்டர்ஸ், it will also have non-doctors who will be logging in and will be watching these series because டாக்டர்ஸ்க்கும் பேஷண்ட்ஸ்க்கும் நடுவுல ஒரு பாலமா இருக்கிறதுக்கு இந்த பப்ளிக் அவேர்னஸ் கமிட்டி உதவும்னு நாங்க நம்புறோம். And I am so happy and glad and grateful to Sampath Kumari ma'am for continuously supporting this initiative. I'm so glad Dr. Meena was able to join us robustly in every single program, and I am so glad to kickstart this session and the season. Dr. Revati Janikaram has joined us.
Now, I take great privilege in inviting our ever enthusiastic Madam Sampath Kumari Madam to give the welcome address. Sampath Kumari Madam is a professor and HOD, OGSSI President, OGSSI Vice President 2022.
No problem.
Over to you, ma'am,
Yes.
to give the welcome address.
Thank you, Dr. Meena and Dr. Sumati. Always the Madras program, I would like to start with Dr. Revati Madam, Dr. Ramani Madam, Dr. Anjalakshmi Madam. Anyway, welcome to Revati Madam. This is the Thinnai debate, which is the brainchild of our Dr. Sumati Premananda. See, as she told, it will be a link between for us and the patients. Today's topic is the second stage of labor, instrumental delivery or LSES. For this, we have the two, it is like Rahul and Lakshmanan. We'll be talking on the instrumental delivery and the LSES, and our judge and the moderator, not only the judge, she will be the moderator and she will be telling what is for and against instrumental and for and against the LSES and what could have been done. So we will go with without wasting time, we will go with the scientific session. Again, thanks to Dr. Sumati Premanand for the wonderful Thinnai debate. As she told, அந்த காலத்துல வில்லேஜ்ல எல்லாம் பார்த்தா எல்லா வீட்லயும் திண்ணை தான் இருக்கும், திண்ணை இல்லாத வீடே கிடையாது. அந்த மாதிரி this debate will continue for in OGSSI forever. Now I welcome our energetic secretary, Dr. Meena Mahalingam, to give the OGSSI prayer.
Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Over to Sumati ma'am to start the session. So Sumati madam is our joint treasurer of OGSSI. Can you share Sumati madam's CV? So madam is the director of Darshan Fertility and Women's Hospital, senior consultant Genesis IVF and Advanced Fertility Clinic, Maruti Medical Center and Hospital. She is the coordinator for the Public Awareness Committee for OGSSI. She is a master trainer of DIRA, No to War OGSSI, Violence Against Women, past co-chairman, Women's Doctors Wing IMA, past state council member IMA, speaker national international conferences, and also she is a poet, traveler and blogger to take over this Thinnai session and continue the proceedings. Over to you, madam.
Thank you, Meena, for the kind introduction. This debate is not about forceps, vacuum versus cesarean section. It is not about tradition versus technology also. It is about, are we making the appropriate choices in that particular circumstance, the operative skill which is required, maternal safety and the neonatal outcome, and the future health and life of two lives, two very important lives. Are we moving away from the instrumental delivery because it is unsafe or because we are uncomfortable? Is second stage cesarean section a life-saving solution, or is it a reflection of the lost expertise? Today, we invite two strong speakers to challenge these assumptions, interpret evidence, and most importantly, provoke reflection on this. Because how we manage the second stage today will define obstetrics for actually the generations to come. We are very glad that Dr. Revati Janakiram, the Vice President of FOGSI South Zone 2016 and President of TMFOG in 2023, was able to join us. And she is the Founder Secretary and past President of Madurai OG Society. She is a Founder President of the Madurai Menopause Society. She is a Zonal Coordinator of the FOGSI ACS HPV Drive. She's a recipient of FOGSI Dr. Durusha Community Services Award, recipient of a Lifetime Achievement Award from IMA of Madurai. She has a lot of accolades, which she has actually tried to fit into one slide. I think it runs into many slides. Thank you so much, ma'am. I kindly invite you to introduce the two speakers.
Thank you. Thank you so much, Sumti. Not only for introducing me, but also for inviting me to kickstart this wonderful Thinnai webinar. As you rightly said, Thinnai is it is going to be very useful for everyone. And one thing that is the toughest and shortest journey a human being undertakes in his whole lifetime is just 10 centimeters from brim to outlet. And that too, the second stage is very, very critical both for the mother as well as fetus. So are we choosing instrumental delivery or C-section? We have got two experts, Dr. Lakshmanan, who is the senior resident in Department of OGSSI. He did MBBS and SRMC and PG from PSG Coimbatore. He is a gold medalist in practical and viva examination in MBBS. He has got Best Paper Presentation in Labour Congress 2023. He has published multiple articles and textbook chapters also. He has presented in national as well as international conferences. And he is much interested in high-risk obstetrics as well as clinical research. And we have got other... can you put Rahul's slide also? Or after that? Okay.
Yeah, yes.
Dr. Rahul Anand, he is an assistant surgeon in Government Commonwealth Hospital, Chidambaram. Research scholar, PG diploma in hospital quality management, MBA quality management, very good. Areas of interest is obstetric medicine, and there are a lot of accolades. Dr. Angela Trees and research. I think he's very much interested in the research works, and he's got the best papers in Sudari Endocrine March 2023 in FOGSI and Yuva FOGSI South Zone also. He has got his best paper awards. And I also heard that from my daughter that she used to talk very nicely, and she has listened to his talk on feedback in one conference also. So I think we are going to have a nice debate between Lakshmanan and Rahul. Let me start with Lakshmanan.
Madam Revati Madam, he is a PhD. He is doing his PhD within 1 hour. Within 6 months,
I know,
he will
Rahul
get his PhD.
Rahul Tane, I research scholar. Excellent. So we've got two so let us be alert and decide how to do and how to proceed. Over to Lakshmanan.
Yeah. Thank you for that introduction, ma'am. Thank you for the opportunity. A very good evening and a very happy new year to everyone. I hope my screen is visible. I'm sharing my screen right now. I hope 2026 is a great year for everyone. And through the span of this year, we will be welcoming around 26 million babies, slightly more than that in India. And everyone has an expectation for a perfect baby. And that is the mission of an obstetrician to get these perfect babies safe and sound to their parents. However, 10 to 15% of patients will require a second stage intervention. And this is certainly a headache to obstetricians as we have to decide to deliver by either instrumentation or a second stage cesarean, and keeping within 30 minutes, the decision to delivery interval should ideally be within 30 minutes. And this is a high stake decision, whether the instrument or the knife. All major organizations, let it be FIGO, NICE, ACOG or RCOG, they recommend assisted vaginal delivery as the first choice method. They consider it to be safe and relatively easy to perform. However, there is a cause for concern as there is a global decline in the AVD rates and a rise in LSCS. So much that in 2018, the World Health Organization had to come out and say, support assisted vaginal birth and prefer them over LSCS. The rate of assisted vaginal deliveries is 2.6% in India, and this is much less than the global average of 5 to 15%, and we are way behind UK and Europe. And second stage cesarean rates are also ever increasing in our country. Whether the share market rises or not, our second stage cesarean has been rising. And there is a common belief that second stage cesareans are safer alternatives to assisted vaginal deliveries. And this is basically based on myths that it's safer for the mother, it's safer for the baby, and it's safer for the obstetrician. However, we have to launch a surgical strike on these myths today, and it's time to make instrumentation great again. I'm here to say it's instrument first and instrument always. And this is the largest meta-analysis performed as far as management options in a second stage section are considered. This was published in September of 2025 in the American Journal of Obstetrics. It involved more than 751,000 patients, 40% of whom were from low and middle income countries. So are instruments more dangerous than second stage cesarean? Whenever we talk about instrumentation, the first thing we're going to hear is instrumentation causes tears. Yes, obstetric anal sphincter injuries are a headache, but the prevalence of them is 6%, 8% with forceps and lesser than 5% with vacuum, overall prevalence being 6.1%. However, it's important to note that 80% of these tears are either grade 3A or 3B, 95% of which would be asymptomatic in 6 months. Not to forget that these are avoidable with adequate episiotomy and adequate perineal support. And the risk of recurrence of these tears is 5% in the next delivery. RCOG in its 29th Green Top guideline does mention that an increasing perineal tear does not necessarily mean poor quality care. It probably indicates better detection and reporting. And appropriate training means we can give a high standard repair, and this reduces the morbidity and the litigation associated with these tears. And going back to our meta-analysis, only with the case of cephalhematoma is instrumental delivery more dangerous than second stage section. And please remember that cephalhematomas are self-limiting and benign. PPH is 2 times more common in the second stage section group. NICU admission rates are 3 times higher. Skull fractures and neonatal death are 6 times higher in the second stage LSCS when compared to instrumental deliveries. And Foxy in its Foxy Focus Bulletin notes that the PPH rate in India is around 4% for vaginal deliveries and 6% for sections, whereas these are around 10% in second stage sections. Please remember that obstetric hemorrhage is the most common killer of mums in our country. Also, maternal satisfaction is much higher with vacuum delivery and forceps delivery as mentioned in the same meta-analysis. And what about secondary outcomes? You might ask, Lakshman, what about the other serious outcomes that we always talk about? This study made it very clear. Second stage cesarean section was in no way superior to instrumental delivery in reducing composite adverse perinatal outcomes. This includes intracranial hemorrhage, subgaleal bleed, retinal hemorrhage, hypoxic ischemic encephalopathy, and developmental impairment. All the reasons that we usually give for preferring a second stage section. There was no statistical significance. And multiple studies report the non-inferiority of instrumental delivery to second stage section as far as neonatal composite outcomes are concerned. The study also talks about failure. This first thing we talk about is tear. The second thing we talk about is what if the instrument fails. So this study mentions that the overall prevalence of failure of instrumentation was 5.85%. Slightly higher with vacuum when compared to forceps. They define failure as being conversion to second stage section, sequential use of instrument, no progress with traction, or a repeated cup dislodgement. So a failed AVD does not mean worse outcomes. Studies have proven that failed instrumentation prior to second stage section was not associated with a higher rate of complications. However, sequential instrumentation was associated with poor neonatal outcomes. Another meta-analysis from the British Journal of Obstetrics compared 20,000 second stage cesareans versus 32,000 vacuum deliveries. There were 133 perinatal deaths in this study, and 70% of which happened in the LSCS group. And only 6% of LSCS occurred within a decision to delivery interval of 30 minutes. And this was known to be, they decided that this was a factor for the increased neonatal morbidity and mortality. And with vacuum delivery, they found that there was a reduction in the perinatal deaths, and with an exception of perineal tear, none of the other complications were higher in the vacuum delivery group. And there was nothing to suggest that second stage section was superior over vacuum in both a high and a low resource setting. So is AVD dangerous for the baby? Not only is there no significant difference in many of the long-term complications and NICU admissions, second stage section increases the respiratory morbidity and also transient tachypnea of the newborn. So now let's talk about the alternative. Let's do a second stage section. Let's go, let's wash, let's take a knife, let's get in and let's deliver the baby. What's the problem with that? It requires more skill. I don't think it's a skill versus scalpel debate. It's skill versus more skill. It's complicated by an impacted fetal head. There's a thinner lower segment, pulled up edematous bladder, distorted anatomy, and please don't forget the twin of surgery, anesthesia, and also a prolonged decision to delivery interval. You need to shift the patient, you need to give anesthesia, you're dependent on lights, you're dependent on your technician. There are more intraoperative complications, injury to the urinary bladder, bowel, ureter. There is difficulty in suturing a thinned out lower segment, injury to uterine vessels, and a second stage section has an increased risk of PPH, infection, sepsis, maternal ICU admissions, obstetric hysterectomy. These are all highly morbid conditions which can even cause mortality. This is apart from the other routine morbidities such as a prolonged NPO, retaining a urinary catheter, a delay in return to routine life. And okay, now you've opened the abdomen, you're not injuring the bladder, you've made a very nice incision, but how are you going to deliver that impacted head? There are so many multiple methods, but however, there is no fixed consensus over which is superior and which is better, which has reduced injuries. What we do know is risk of injuries to the fetal limb and fetal skull are higher with second stage sections. Let it be reverse breech extraction, the push method, or the standard vertex extraction, or nowadays we have a lot of instruments which are helping with the second stage delivery. Let it be fetal pillow. However, these are also not well studied, and it's still really questionable how effective these are. And speaking of tears only happen with 8% of instrument, and 80% of these are 3A and 3B tears. However, angle extensions in second stage sections are as high as 50%. There is 1 in 2 end up with tears, which might very much extend way down the lower segment or into any of the surrounding vessels. Also, in low and middle income countries, the second stage section has higher mortality, injury to critical structures, poorer perinatal outcomes. The second stage section neither improves the outcome nor protects the neonate from birth trauma. So I don't see why there's even a debate on why we should not try instrument first. So I think it's very safe to say that a second stage section is the most morbid cesarean we can perform. And an extension, this is the most morbid way to deliver a baby. So assisted vaginal delivery risks are immediate and visible, which is one of the reasons why obstetricians fear them. However, LSCS risks are delayed, maternal, and cumulative in the long run. Second stage does not eliminate any of the risks. It's just transferring it to the mother, nor does it improve the neonatal outcomes. There is no evidence to suggest that. Even in prematurity, instrument is superior to second stage section, as noted in a study of 2,800 deliveries. Cesarean delivery had poorer neonatal outcomes, mainly because of the respiratory morbidity. We also have to think about the future lady and future pregnancies. C-section at full dilation was an independent risk factor for spontaneous preterm birth, including delivery before 34 weeks. And you've done a first section. What are you going to do in the second pregnancy? How many centers actually give a proper TOLAC trial? The success of TOLACs is 71%. However, this reduces to 50 to 60% with a second stage LSCS. And even then, 40% of these patients will require an instrumental delivery. So what are you going to do now? Do another second stage cesarean. And also TOLAC or VBAC after a previous second stage section is associated with higher scar dehiscence and rupture. Even if you're not giving a TOLAC, you're doing a direct repeat section, there is going to be increased adhesions, difficulty with bladder dissection, increased scar rupture and dehiscence, not to forget placenta accreta spectrum, which is the new obstetric pandemic. Whereas if you just choose to put that instrument, do it carefully, the chance of a spontaneous term vaginal delivery in the next pregnancy is 80%. I'm not talking about a repeat instrument, I'm talking about a repeat vaginal delivery. With good training, most deliver by instrumentation and only 3% require second stage cesarean. However, in our country, it's the inverse, and it's not a loss of skill. It is a loss of skill, pardon me, and it is not safe for obstetrics. So why is this change? It's because we live in the age of evidence-based medicine. It's safe to say that evidence-based medicine means litigation-based medicine. There are fear of neonatal complications and a lack of training and resources. So this is more a debate of good obstetrics versus defensive obstetrics and appropriate intervention versus avoidable major surgery. So there is reduced training in vacuum and forceps. There is reduced supervised experience. How many times do we even allow our trainees to do it on a mannequin? Seriously. And this study from Singapore comparing second stage sections and instrumental deliveries, in this study, 72% of patients had a successful instrumental delivery. Failure rate was just 2.7%, and they attribute this to their accurate assessment. However, they note there is a 5% increase in second stage section over 2 years. It's also noteworthy that 70% of instrumental deliveries happen in office hours, and they note that there is a reluctance among junior consultants and residents in attempting instrumentation, and they think it's rather a lack of confidence rather than a lack of skill, because the same junior consultants apply the instrument and the consultant is standing behind them, and there is a fear of instrumentation and an increased fear of litigation. So why does instrumentation fail? It's basically because of incorrect assessment, inappropriate instrumentation, not knowing when to stop, resorting to methods such as fundal pressure and sequential instrumentation, which are unscientific. There is no evidence to say that fundal pressure helps. It does not reduce the duration of second stage labor. It is associated with poorer outcomes for the baby, more injuries, and trauma to the mum. There are also other reasons. We do live in an age of not just litigation based obstetrics. We live in an age where we are mobbed, where we have to handle thugs. And even in the case of audits, we have people conducting audits with the preset notion that the obstetrician is wrong. We have seen so many instances in the past year. So what should we do instead? We should focus on training. And also intrapartum ultrasound. Most labor rooms now have access to ultrasound, at least especially in Tamil Nadu. And intrapartum ultrasound is easy to learn. It has a shorter learning curve. We can use to screen and detect earlier. Something as simple as giving a perineal massage, maintaining a proper partogram with accurate regular documentation helps us to reduce section rates. And this is also from a PubMed study. So is this really a skill versus scalpel debate? I don't think so. It's skill versus more skill. I'm sorry to say this, but I think it's safe to say if someone does not know how to apply an instrument, they should not be conducting a second stage section, because that requires more skill, more thought, more pace. It's always easier to pull the rabbit out of the hat rather than go make a hole on the other side of the rat, try to yank the rabbit by its foot, hand, ear, whatever it is, and then try to suture the hat back together like it was normal. A decision that we make in 10 minutes has lifelong implications, not just to us, but to a mum and a child. The student of today is the teacher of tomorrow. If we do not train residents of today, no one is going to be applying instruments, because it's going to be a dying art. And that means we'll have a surge in second stage sections, more morbidity, more repeat sections, more placenta accreta spectrum, and more paradoxical litigation. Basically, everything we want to avoid by not doing instrumentation, we are just going to make that happen. And skill erosion should not define the standard of care. Instrumentation is gold. It is guideline endorsed. Second stage section is high risk, does not eliminate any of the morbidity. Poor training means we need better training. We cannot replace vaginal birth with a major abdominal surgery. So now, Dr. Rahul Anand, the nation wants to know, or at least the people in this attending this webinar want to know, why you would like to do a second stage cesarean despite all evidence clearly being against it. Why so much of defensive obstetrics? Obstetrics is like test cricket, but even then we should know when to attack. And with that, the proposition concludes its arguments. Thank you.
Excellent, Dr. Lakshmanan. You have brought up two important points. One is instrumental delivery, vaginal delivery in second stage is a weaning art, which has to be revived. And second thing is that LSCS in second stage is equally traumatic and complicated for both mother and fetus. Let us see what Rahul is going to answer for this.
Unmute yourself, Rahul.
Am I audible, madam?
Yeah, your screen is seen and you're audible. You can start.
Yeah. An excellent talk at the outset, Dr. Lakshmanan. You made a very strong argument for the proposition. Let us see how well I defend it from the opponent side. So I begin my presentation with the pilot sitting in the cockpit trying to land the aircraft. So how relevant is it to my second stage cesarean? Hopefully you will understand it by the end of the presentation.
Yeah.
Yeah. So to begin with, when skill becomes showmanship, My dear proponent of forceps has sugar-coated the outcome so beautifully, but obstetrics is not a mere demonstration of virtuosity. Patient safety is definitely more important than the obstetrician's ego. A single bad forceps is remembered for a lifetime. A difficult cesarean, however, is often forgotten after discharge. This debate is not about courage or competence, it is about risk containment. Yeah. So what are we really comparing here? Two very difficult choices, not one right and one wrong. Both choices have high stakes, they are time critical, they are operator dependent, and they are legally vulnerable. The question is definitely not which is superior. The real question is which option offers greater predictability and controllability in today's practice environment. Let's talk about the illusion of easy forceps. Lakshman has told beautiful indications and techniques of how to apply the instrument. But is it really suitable, and is it truly clear at 2 a.m. in the middle of a busy labor room when the obstetrician is exhausted in a resource-limited setting? The station assessment is often subjective and examiner dependent. The degree of rotation is often misjudged. The presence of caput and molding often distorts major important anatomical landmarks which are very crucial for applying the instrument. An occipito posterior can easily masquerade as an occipito anterior presentation. The exhausted mother will give us only compromised cooperation. So the reality is forceps decision happens in gray zones, where the clarity and the thought processing of the obstetrician is already compounded with so much emotional stress. It is not a textbook related simple checklist that we can tick off. So what is the margin of error? The catastrophe lives there. Forceps and vacuum definitely have a very, very narrow therapeutic window when it comes to neonatal safety. A perfect case goes often unreported with excellent outcomes, whereas even a slight misjudgment causes irreversible injury to the baby. Whereas in a cesarean section, there is definitely a larger margin for correction, because very simply the maternal health status is given over to the head and to be taken care of by the anesthetist. Escalation to other procedures is definitely possible, because once the baby comes out, you don't have the urgency of time. Complications are usually more maternal and more delayed in their presentation, whereas in a forceps, the errors are immediate and they manifest on the baby. So let us talk about the catastrophe of failed forceps, which my proponent has conveniently chosen to ignore. It contains the worst outcomes of both worlds: prolonged hypoxia, traumatic extraction attempt, emergency second stage cesarean under stress. It will increase the risks of postpartum hemorrhage, it will increase the bladder injuries, and it will increase neonatal asphyxia. A failed forceps is definitely not a neutral event. It is a multiplier of harm. There are peculiar complications associated with instrumental vaginal deliveries, such as the neonatal complications, including intracranial hemorrhage, subgaleal hematoma, skull fractures, and nerve injuries, which are definitely more in cases of instrumental vaginal deliveries. And maternal complications, which are specific, are 3rd and 4th degree perineal tears, pelvic floor dysfunction, long-term anal incontinence, and dyspareunia, which is often overlooked. Moving on to the neonatal outcomes, ask your pediatrician before applying the instrument. He will give you the uncomfortable truth. The baby definitely pays first. Forceps injuries are visible and they are immediate. Cesarean complications are more maternal. We are definitely in a better position to explain it to them. Whereas a baby with a neurological sequelae, the question won't be to you. The question will be to the pediatrician. He will very coolly say, it is because of the forceps, go and ask the obstetrician. The society at large, the courts of litigation, and the immediate family members may forgive maternal morbidity if you clearly explain it to them, but they will definitely not forgive neurological injury to the neonate. This asymmetry matters in clinical decision making. So what does the evidence say? So before going to my evidence, he has quoted the American Journal of Obstetrics, the recent meta-analysis of more than 7 lakh women. So this number is pretty misleading. They have taken the low and middle income countries of all the available women who had underwent a second stage cesarean section. The debate, I think, should be clarified at this point. This is not a debate of whether an instrumental vaginal delivery outcome is better than that of a second stage cesarean done for obstructed labor or an arrest of descent. It is the forceps, or you are taking it for a second stage cesarean. That particular article included women who had obstructed labor, who had intrauterine fetal demises also. So that will definitely skew the impression. So the other systematic reviews and meta-analysis showed comparable perinatal mortality. Instrumental vaginal delivery is definitely associated with higher trauma to the neonate and increased maternal anal sphincter injury. Second stage cesarean, I do agree, is associated with higher maternal morbidity, but definitely lower severe neonatal trauma. Second stage cesarean section shifts the risk to the mother. So this is ethically relevant. Ask any mother, she will gladly trade her life or her uterus for the well-being of the baby. So let us move on to a few randomized control trials and observational evidence. This is a bit of a struggle because of the ethical constraints to design the study, and definitely operator skill variability plays an important role, and most of these decisions are taken in emergency context. So the most of the high quality evidence is from large observational cohorts and retrospective registry based studies. These consistently show that forceps outcomes are highly operator dependent, whereas cesarean deliveries are system dependent because you have a protocol in place. So what the guidelines say and what they do not say. Again, my proponent has clearly shadowed the guidelines and presented a very shady impression that instrumental vaginal delivery is the first and the best. No. The American College of Obstetrics and Gynecology clearly states instrumental delivery requires expertise and training and emphasizes on informed consent. So how good are we at applying that in our modern obstetrics nowadays? And the Royal College of Obstetrics and Gynecology also says that the declining forceps skills has to be acknowledged. It recommends realistic assessment of operator competence. No guideline mandates forceps or vacuum. They all say go for an instrumental delivery if you are skilled and if your institution has the appropriate facility to take care of the complications. Moving on to the waning art of forceps, this was very casually skirted off by my proponent. That let's welcome the training reality in India, that is reduced exposure during residency, because almost all the teaching hospitals have demonstrated a dramatic fall in the rates of instrumental vaginal delivery. There is a definitive fear of litigation. So fewer consultants are willing to, even if they apply an instrument, they wanted to do it personally. They don't allow their interns or residents to do it. The skill is concentrated in a very shrinking small pool of elite obstetricians and gynecologists. Fresh residents definitely lack confidence in applying instruments. A procedure that depends on disappearing expertise is definitely not sustainable. Defensive medicine, a lot of malice is thrown towards this term. Defensive medicine does not equate cowardice. It is rational risk management. The courts judge outcomes, not the intent of the obstetrician. The standard of care is often retrospective. Even correctly applied forceps can be indefensible in a litigation in the court of law. Caesarean section is definitely seen as defensible, but is acceptable both by the healthcare professionals and by the families and the court of law. It is definitely easier to justify medico-legally. Defensive medicine, as per the latest guidelines, is now part of the ethical practice. So let us look at the Indian litigation reality. Forceps is definitely in the dock. There are numerous cases involving forceps where cerebral palsy has occurred, facial palsy has occurred, neonatal death has occurred. The common themes before awarding compensation by the judge was why forceps? Why not cesarean? Was consent really informed and explained? The public perception and the media trials often equate forceps to avoidable injury. So let us talk about informed consent. It is really a fiction at 2 a.m. Let's be honest. Can true consent be actually taken in the second stage, where the woman is exhausted, she's already in severe pain, she's emotionally vulnerable, and she'll definitely not understand the technical jargon? Meaningful consent must be given and obtained antenatally. Yet, forceps risks are very rarely explained antenatally, whereas cesarean risks are very commonly discussed. This asymmetry in consent explanation definitely matters legally and also ethically. So reproductive autonomy and patient choice are the new buzzwords of this decade. Whose body are we talking about? Who is the ultimate risk taker? It is the patient, it is the mother. The mother bears the physical consequences, the psychological trauma of having a differently abled child. She is the one who is going to face the social stigma. The obstetrician at the most faces a short-term stress. Autonomy means patient's risk tolerance matters. Many women prefer cesarean section over instrumental trauma, and we definitely have to give credence to their opinion also. The myth of quick forceps saves the baby has to be dispelled. Speed is definitely not safety. Forceps does not guarantee instant delivery. Incorrect application merely wastes time. Failed attempt delays definitive management by a second stage cesarean section. A planned cesarean may be slower initially, but it is definitely safer to the baby and the mother overall. Looking into the second stage cesarean section, it does carry risks, but they are all known risks because we are operating in a known territory. Predictability is not a weakness. In fact, it is a strength. Before going in and scrubbing for a second cesarean, you anticipate hemorrhage, you anticipate bladder injury, and you definitely anticipate infection. So once you anticipate, it becomes manageable because you'll definitely have a team. And these are all auditable complications. So when something is auditable, it will definitely be improvisable. The risks are not innate as that of the forceps. Modern obstetric systems value safety over individual brilliance. Indian consumer court reality shows a very uncomfortable truth. What the consumer forums actually examine is, was a safer alternative available? Was there any urgency preventing cesarean section? Was the risk of forceps explicitly explained and documented? And was the outcome avoidable with a different choice? Skill, experience of the obstetrician, the intent to deliver a baby, all of that we obstetricians definitely possess, but they are all considered only as secondary events. So look at the patterns seen in Indian judgments. Forceps-associated neonatal injury cases are commonly framed as deficiency in service, failure of the obstetrician to exercise reasonable standard of care. The courts frequently conclude when cesarean facilities were available, instrument delivery was not justified. Second stage cesarean section is repeatedly cited as a safer alternative that was not exercised. So how courts view documentation? They don't care about experience of the obstetrician. They don't care whether the forceps was applied and it was technically correct. They don't look into the emergent nature of this decision-making time. So what really matters was why cesarean was not chosen, whether risks were explained in advance, and whether the outcome was foreseeable. The judicial bias is definitely there. It is unspoken, but it is very consistent. A damaged uterus can recover, a damaged child cannot. Maternal morbidity is often seen as an acceptable risk of pregnancy, whereas neonatal neurological injury is seen as negligence unless otherwise proved. Cesarean section occurs with its own defensible complications, whereas forceps-related neonatal injuries often lead to an indefensible outcome. In Indian consumer courts, outcome outweighs expertise. So what is the future of obstetrics? What direction are we actually heading? You might all agree with me on this point. Patients are becoming more and more aware because of Google Doctor. There is zero tolerance for neonatal disability. Even a subconjunctival hemorrhage is not tolerated by the parents. There is a rising litigation issue. The incidence of litigation has increased 12-fold compared to the previous decade. And there is a definitive decline in forceps expertise. Cesarean section in the second stage, consequently, is definitely going to increase. We have to look into measures to standardize them so that we become safer with better techniques. This is a step further into the future. This is evolution. This is not failure. So in a nutshell, I'm not asking for a ban of forceps, and I'm definitely not saying cesarean section is risk-free. And I'm not advocating that skilled forceps has no role. What current reality is saying is forceps should be exceptional and not reflexive. Second stage cesarean definitely deserves legitimacy. It has its own position in our labor room, and it should not be stigmatized like how my dear proponent effectively did it. A practical safety check for those listening before decision making is, before choosing the mode of delivery, ask yourself, is this decision reproducible across operators and settings? Will your colleague take the same decision? Will your chief take the same decision? Will the auditor sitting at the government heads take the same decision? Does it minimize irreversible neonatal harm? Does it allow escalation if the first plan fails? Can it clearly be justified to the patient and to a court, God forbid that happens? The safest option is not the most skillful one. It is the one with the smallest margin for catastrophic error. So the final position statement from me and from the guidelines are, both the options of a second stage cesarean and an instrumental vaginal delivery carry serious risks. Blanket recommendations that instrumental vaginal delivery are the first and the best option are definitely unsafe. In modern safety, before making a decision, we should take into the consideration patient safety, the legal reality and the political climate of the place which we are practicing, the training limitations of our own obstetricians as well. Second stage cesarean will and must play a growing role in the future of obstetrics. So coming back to the cockpit. So as you see, a pilot is trying to land his aircraft into the runway. Imagine this is happening at 2 a.m. where he's already traveled for 24 hours and he's exhausted. Suddenly the engine malfires. What would you do? Would you want him to take all his decisions independently and do a manual landing? Or would you seek the help of the autopilot and the team which is sitting back at the cabin? The autopilot landing is definitely safe. The forceps is equivalent to the manual landing, whereas the second stage cesarean is definitely equivalent to the autopilot landing. The forceps requires exceptional pilot skill, perfect situational awareness and optimal conditions. Successful landings are definitely admired, I agree. You'll be hailed as a hero if you put a forceps and the baby comes out fine. But the errors are immediate, they are catastrophic and often unrecoverable. Whereas in the autopilot landing of a second stage cesarean, it is designed for predictability, redundancy where you can fall back on safer cushions, and error containment. I agree it is not heroic, neither is it elegant, but it is standardized, it is definitely auditable, providing the scope for much needed improvement, and it is safer in adverse conditions. So why does the aviation industry choose the autopilot? Majority of our checklists we use in modern medicine came from the aviation industry. So let us take this example as well. The aviation chose the autopilot mode not because pilots lack skill, because human error is definitely inevitable. Consequences of failure are unacceptable. Automation reduces variance, not responsibility. So translating it into obstetrics, the neonatal brain can be equated to that of a passenger's lives. The pelvic floor is that of an aircraft structure. Even if damaged, it can be repaired. Modern obstetrics, like the aviation industry, prioritizes system safety, reproducibility repeatedly, time and again, and outcome over heroics. When stakes are the highest, we choose the method that leaves the least room for human error. The forceps celebrates the pilot. The second stage cesarean protects all the passengers without any risk. To end the argument, in obstetrics, the bravest decision is not the boldest maneuver, but the one that leaves the least room for irreversible harm. As medicine evolves, second stage cesarean section is not a retreat from skill. It is actually an advance towards safety. I would definitely like to hear my dear proponent speak in his rebuttal and answer this one question. If the baby develops permanent neurological injury after his forceps, will the parents be consoled by the fact that the obstetrician demonstrated excellent skill and followed guidelines and meta-analysis and systematic reviews? Or will they ask only this single question? Why wasn't a cesarean done earlier? I rest my case for second stage cesarean section. Over to the proponent for his rebuttal. Thank you.
Dr. Rao, you have brought out all valid points in C-section. And I am sure, in case you are asked to talk on the other side also as a proponent, then also you will bring out a lot of positive points also. I know. Okay. Over to Lakshman.
It was a very interesting set of points from my opponent. And I'm very happy to see another aviation buff who's also a male gynecologist. I just want to point out that though autopilot helps in automation, it helps fly the flight, it's important to remember that it does not land the flight, nor does it take off. It's just passing from one gateway point to another gateway point. And please remember that the pilot usually has a rotational crew. They have set guidelines on how long they can rest, how long they can sleep, when they should be flying. That's not the case with an obstetrician or a doctor. We are there 24/7. And I think all of us in our labor rooms, we've done, even in a private medical college, we conduct 300, 400 deliveries. So the only thing heroic about us is not doing the section or applying the instrumentation. There is no heroism. This is science. And I think our science and our training has prepared us to go through the so-called exhausting, busy labor rooms. I don't think anyone has ever felt so exhausted they want to run away from the labor room. We want to see through our shift. And not to forget that most of the times it came back to poor training. A well-trained pilot will be able to make a smooth landing at 2 a.m., 3 a.m. with his controls inverted onto a runway. He'll also be able to land it in the Hudson River, as we've seen. So that same thing goes for an obstetrician. So not being trained appropriately is not going to, not being trained appropriately means that your section can also go as wrong as putting an instrument. And there is nothing to say that there's going to be reduced neurological morbidity in a second stage section, because one of the major reasons for the neurological morbidity is a prolonged second stage where the baby is asphyxiated. Not to forget that a second stage section is going to take longer. Yes, forceps is not instant. It requires proper application. You also need to remember a lot of mistakes happen because of I would really appreciate it if the chat popper does not keep popping up in between. Sorry for that. And as I was saying, neurological injury is not just because of forceps application. It's because of incorrect application. You have a new SR or a new resident who wants to be heroic and applies and experiments. I'm not talking about experimentation. We are not here debating malpractice. If you want to learn how to apply Simpson's forceps properly, please go to Chidambaram. Dr. Rahul will teach you how to apply Simpson's. If you want to learn how to apply axis traction, go to Dr. Tarun Joseph or so many other obstetricians in Chennai. They will teach you like how they have taught me. So it's really about a question of training, knowing your limitations is important, what you can do, what you cannot do. And Dr. Rahul has very conveniently ignored and he has buried vacuum deliveries completely. He has only spoken about forceps the entire time. He's forgotten there is a second instrument called vacuum, and vacuum has lesser neurological injury, and all complications are much lesser with vacuum. Maybe with an exception of in some studies is the perineal tear. Apart from, and other than that, sorry. Also, I do want to point out that most of the evidence that I've quoted are recent evidences from 2023, 2024. If you go back to Dr. Rahul's slides, you'll see he has evidence from 1999, 2004. So most of these are probably done and dusted. And this is really old evidence. You do have to look at what is recent. And you also did mention about everything is forgotten with a difficult cesarean. Everything is forgotten because you have hidden everything conveniently under your fan and steel incision with a very nice 3-0 monocryl or a 2-0 ethylon. And the mother is never going to see what all has happened. The next person to see what all has happened inside is going to be the next obstetrician who does the repeat cesarean. And you also spoke about a blame game being played. Yes, we cannot deny that. I did have a slide on how people sitting in audits and in courts come with the preset notion that doctors are wrong. However, we just have to fight this. We cannot chicken out and run away and hide. We need more high quality evidence, and all these evidences and meta-analysis can be used, do stand in a court of law, that my instrument is not what has caused this neurological sequelae. It can happen. It's not going to be preventable just because we are doing a cesarean. Cesareans also have their fair share of problems. And as I said, yes, cesarean does deserve legitimacy. It deserves legitimacy when instrumentation is not possible or when instrumentation fails. It should not be the next immediate option, because if that is the case, you will just find all second stage deliveries being done by cesareans. Eventually, 30 years down the line, when you and me are going to retire or we're senior professors, we'll only see cesarean sections being done and there will not be any vaginal deliveries. And as mentioned, instrumentation only goes wrong in less than 5% of the cases. It's not frequent. And yes, I do understand the mom goes through so much in pregnancy. Despite all her suffering, there's only one question she asks: doctor, is my child fine? And we have to give her a healthy baby. That's the main expectation of the mother, and that is important. But I don't think by replacing an instrumentation or section we are going to assure that. Ultimately, and it's not like before where you're going to blindly apply an instrumentation. Use an ultrasound probe, see your presentation, see if it's occipito-posterior or anterior. Not to forget that our training means that with the PV examination, we should be able to make out where the sinciput is and occiput is. I did make a statement that if you can't apply an instrument properly, you shouldn't do a section. If you can't do a PV, I'm sorry, I don't think you should be in obstetrics. I don't mean to hurt anyone. It's just a part of the debate. Yeah, and usually we are talking about instrumentation at the +2 station, where the head has negotiated the entire pelvis, the power, the passenger, and the passage. Everything has worked out, and it's come there and it's standing at your door. You just have to open the door and welcome the visitor, or rather the occupant in this case. But you want to push it all the way up in the reverse way, and you want to take it out through the abdomen. It makes no sense. As I said, it's easier to pull the rabbit out of the hat. And I would conclude my rebuttal with that. But I do have to appreciate Dr. Rahul. He did hit me in so many ways I did not expect. So I really enjoyed being in this debate. Thank you.
Awesome, awesome. Revati ma'am.
Yeah, really, both of them have done a wonderful job. And as he said, Lakshman at the end, he said, see, not even ultrasound, simple vaginal examination. When I was HO, first, once the membrane, the first PV finding should include the sagittal suture direction, sinciput, occiput position. They have to mention that. Because only then, even if it is going to be a normal vaginal delivery, suppose if it is going to be a phase 2 PVs, you will anticipate the perineal trauma. How?
Ma'am, since you're traveling, you can cut off the video so that your audio is interrupted. Ma'am, can you stop your video because the connection is slower? So if you do your audio, yeah, please carry on, ma'am.
Is it better now?
Yes, ma'am. Much better. Yes, ma'am.
Very clear.
Okay.
Very clear.
Okay. So it is not exactly a debate between whether to do LSCS or instrumental delivery during second stage. Okay, that's not like that, because each and every case is different. It depends upon the clinical scenario. Okay, each obstetric patient at the second stage is different. So you have to judge very correctly. The clinical judgment, that is very, very important. So developing skill is not only in doing cesarean section, not only in applying forceps. You should develop skill to assess properly. That is the thing very, very important, which you learn in the labor ward. Okay, that is very important. And second thing is that it is not just a cookbook approach. Now, 1+1+2, you will do like this. It is not like that in obstetrics. Never. So you have to see in which patient what to do. And as you said, the vacuum was forgotten by Rahul. You know one thing, we had a dean, Dr. Tara, pediatrician. She was the dean there in DRS. At that time, because she was all the time telling that instrumental delivery will cause trauma to the neonate. So she just banned and removed vacuum from the labor ward itself. So that goes like the individual whims and fans. But remember one thing, vacuum is very good. And you know very well, even in the cesarean C-section, you are using the vacuum. That is another thing. And we have got this ward-on device and all those things for easy, safe vaginal delivery also. So ultimately, what you should know is that you have this, especially the interns, the student is itself, you should pay attention to learn and attend as many cases as possible. I used to say the PG is not take even one day leave, because each and every delivery you learn something. So you to make a decision. Now at this stage, in this particular patient, taking this decision will work out better for the mother and baby. So that you learn the experience only by seeing patients and doing this case. So that is very important. And what we have to do, we have to develop the skill to assess the clinical judgment. Of course, it also has been of that is very well known. As right and left, we used 8%. Common people do that without much of a daily trauma or baby. And we have done the persistent oxytocin application of forceps.
Ma'am, I think this is getting interrupted because of the problem in connection, because you're in the train. We are so happy that you were able to join us. Can you give us a concluding remark, ma'am? Sampath, ma'am.
Madam's voice is a wonderful talk by both the speakers. Rahul and Lakshman, they justified the topic given to them. So, as Madam was talking, each case has to be individualized. So, it depends on the case and how you are trained and how you are going to apply. This is our judgment. Wonderful, Rahul and Lakshman. Fantastic.
Thank you, madam.
Thank you.
Ma'am.
Thank you. And I take an opportunity to, first of all, I enjoyed the session as a convener. That's all I can say. I really enjoyed the session. And I could see that there was no waning in the number of participants. They were only increasing. The number of participants were only increasing, and they have stayed till the end.
Sumati,
That means
participant
that's
is
real
not
success.
at all. Sumati, participant is not at all an indication, because it is in the YouTube. From the YouTube, many viewers are viewing. So the participant don't take into consideration. Definitely in the YouTube, everyone will see. Fantastic talk.
What I was trying to say was, they stayed back to watch the entire thing. Whoever logged in stayed back to watch the entire thing. So that is a big success for Lakshman and Rahul. And I'm so glad they did such a detailed debate on each other. Thank you so much, Dr. Meena.
Thank you. Thank you so much.
If the topic was given both in reverse also, they would have done a good job.
That's what I said.
Anyway,
the take-home message is doing section alone is not beneficial, or going for an instrument delivery is not essential. So you have to take a proper decision. Public also should know that. Only this could have been done, or this could have been done by the doctor. Not like that.
decision by that doctor attending the case. Okay. Thank you. Thank you.
Thank you,
Wonderful
madam.
talk. Thank you very much.
Dr. Meena.
Thank you. Meena, formal
Thank
vote
you
of thanks
so much.
or anything? The
Nothing, ma'am.
chat box, only
Chat
appreciation
box.
we can see. Only
Yes.
appreciations. Other than that, can I
Yes,
get
yes.
recorded webinar? It will be in the YouTube.
Yes,
So,
yes.
neurological.
This will be posted.
Yes.
This will be posted on the YouTube. It will be with
Okay.
OGSSI as
Okay,
well as in the YouTube. Yes, Meena.
So we could see, actually, many people have logged in, as Madam was rightly saying. We had Palniappan sir logging in for Lakshmanan sir, Lakshmanan from Ramchandra, now Dana ma'am. So, and Rahul from our side. Like, we like viewing both the ends and having a very good debate. They really spoke so well, thinking that we should do this during our practice. That is what we felt when we were listening to the talk. Basically, it is a shared decision making. So it was wonderfully brought out by both Rahul and Dr. Lakshmanan. Thank you so much. Thank you, Revati ma'am, in spite of the busy schedule, logging in and giving us all the concluding remarks. And thank you, Sampath ma'am, for having had this wonderful debate. And thank you, Sumati Premanand ma'am, for having wonderfully convened the session. Very nice. Basically, the topic chosen was also nice, and the speakers as well. Thank you so much. And we had a wonderful set of delegates who are really enjoying the session. Basically, it is taking home lot of points from all the ACOG, RCOG, NICE guideline, the WHO, all the reviews which we could not have read in this particular shorter time. They have made it really clear. And thank you so much. Thanks all the delegates for joining in large numbers, and also the Sri events who have given a seamless platform for us to enjoy this webinar. Thank you so much for the wonderful session. Thank you.
The main plus
Thank you
point
then.
is evidence based. Both of them
Yes.
have given a lot of meta analysis, RCOG guidelines. Anyway, hats off to Rahul and Lakshman. Thanks, Sumati, Meena.
Thank you,
And
ma'am.
Revati
Thank
madam,
you.
always with us. Thank you, madam. And
Thank you,
our
ma'am.
Thank you.
delegate.
Thank you
Thank
so
you
much.
for thanks to every one of you for taking the time just after the New Year celebration to kickstart this with the robust evidence-based medicine practice. Thank you so much.
Thank you. Thank
And
you.
also,
Happy
one
New
more
Year
thing,
to
we
all.
could finish on time. Yeah.
Mm.
Happy New
Yeah.
Year.
Thank you.
Thank you,
So
madam.
we'll meet again. Bye-bye.
Yes.
Bye-bye.
Bye.
Yeah,
Bye.
welcome
Bye.
everyone for the second Sunday CME. Thank you.
Yes. Thank you.
Welcome.
Bye-bye.